Okay, good morning, everybody. Can everybody hear okay? Yeah. Well, it's a great pleasure to be here, and it's a great pleasure to speak at this conference, so thank you very much for the invitation. And I'd also like to take this opportunity to welcome everybody to Sheffield, which is a city I love. And I've been here far too many years. I can't believe how long I've been here. So I came here to do my training in 1983 with the intention of leaving once I'd qualified, and here I am. So it's a fantastic city, and I hope you enjoy your time here, those who are visiting. And I'd particularly like to welcome the international visitors who are here for the conference. So my presentation topic then is conquering research impact, reaching the summit, making a difference, and surviving. So for this, yesterday we had a fantastic talk from Hugh McKenna about the Research Excellence Framework, which is a very academic focus to it. And I'd like to pivot the gaze a bit this morning away from the ref and towards a more clinical focus, which is about change in practice. I'm going to just summarise a few of the main points that I hope will come out of the presentation this morning. So for those of you who got up at 6 o'clock in the morning for a run, just listen for the next minute or so, and then you can have a little snooze. So what I was going to, I think some of my main points are, as has already been said at this conference, reaching the summit is not merely about reaching the end of a research project. It is about achieving impact. The reason we do research is to apply it in practice and make a difference. And I'm sure a lot of academic professions can say that, but surely we can as nurses. And it's the making the difference that's important. But it's also about survival, and I think we all have challenging clinical and academic posts. So, and going that extra mile to make a difference, achieve impact, is quite hard, and survival is important. But also, I think as nurses, it should be enjoyable. You know, there's a lot of reward to be had from making a difference. The other point I'd like to make is that research impact is not just about those big NIHR studies. We'll hear a lot about some fantastic research that's been done, big programme grants and big research council studies. But for me, we shouldn't underestimate the difference that can be made from small studies. And I think in nursing particularly, that's true. And I think that's true for a number of reasons. Firstly, by implementing research in practice, whether it's your own research or other people's, for that person that you're looking after, that will make a difference. And the other thing, of course, is that anybody who moves into a research career or big clinical academic career, whatever the nature, they will start with a small project. You've got to start small and build from there. So don't underestimate the value of a small project. I think the other point that I'd really like to make is the value of long-term relationships and collaborations. And without those, impact won't happen. And the final point that I hope will come out of this morning's presentation is that co-production, which is something that I've learnt about in the last few years through working with the Translating Knowledge into Action theme of the Yorkshire and Humber Clark, TK2A. I think co-production has a lot that can offer, not just academic, in an academic field, but by clinicians and academics working together. So those are the points I hope will come out from the presentation today in terms of reaching the summit. And the only reasons that I've got a summit analogy is so that I can have an excuse to show a nice picture of a mountain, because I love mountains. But before I start, just a little bit about me. As I said, I trained in Sheffield. I work in the School of Nursing Midwifery, which as of yesterday is called the Division of Nursing Midwifery at the University of Sheffield. And I've got a huge pleasure to work with some amazing colleagues in South Yorkshire and in the university and in the NHS. And in the university, I'm lucky enough to work with some great colleagues with the Strategic Research Alliance that we have with the Royal College of Nursing. And in December this year, we'll be 2 years into a 5-year Alliance, and it's been fantastic to work and be involved in that. But more importantly for today's talk is I have some fantastic partnerships with clinical practice and also local and national charities and community organisations. And for me, I think that's where the potential for impact lies. It's the relationships that I have with those people. And we hear an awful lot, as I was saying, the approach and focus of this keynote is really to try and think clinically. And we hear a lot about research impact from the perspective of academics, and that is important. But I'd like to take us back to where a lot of us started, and I certainly started, and I'm sure a lot of you did too, and that is being in the clinical area or in a care setting where you are looking after patients or their families, and you see that something's not right and you're driven to try and do something about it. And I think for a lot of us, that's how we get involved in research, whether that's about searching the existing literature or getting out there and getting involved in research ourselves. The thing is, though, of course, that as we go on in our careers, we get influenced by other agendas, and they're often quite political agendas, in terms of the organisations we work in and bigger professional pressures. And we do need to be aware and understand these agendas if we're going to influence change and achieve impact. But I feel that we can't afford to let these agendas derail us from our original intention. And our original goal and motivation is often very simple. It's about making a difference, and it's about trying to improve the lives of the people that we come across in healthcare, whether that's the lives of patients, family carers, staff, or the wider community. And there are many and varied ways of achieving this. That can be achieved through improvements in direct care, systems, changes in organisations, developing better understanding of patients and their experience and their motivations for behaving in particular ways. And we can generate understanding of new interventions and policies. So I think we need to keep affiliated to that goal about making a difference, and by achieving impact, by sort of making a difference to the lives of the people that we work with. So before I go on, though, I'd like to kind of get a bit of an idea about the audience that we've got here. So how many of you would say that you work primarily in an academic role? Okay. And how many of you work primarily in a clinical or care setting? Okay. And anybody who describe themselves as anything else other? Just a few. Okay, thanks very much. And I think that's really encouraging that we've got a really good mix of clinical care setting professionals and people working in an academic environment. And I feel that this conference, for me, has always been a fantastic opportunity to have those discussions with people in both areas of work, so that we can work together to develop research ideas that are really valuable, but also so that we can have the discussions about how we implement research into practice and make a difference and achieve impact. So moving on to the presentation then, what I'm going to do is just talk a little bit about research impact and definitions and interpretations. I'm then going to talk about what I think are some important strategies in achieving impact. I'm going to provide a couple of examples, and they're examples of people who I know are in the audience and that I've worked with over the years, mainly from the TK2A theme in the Clark, and then pull together with a few final messages. So, first of all, in terms of definitions, I'd like to start by reflecting on what we mean by research impact and ask whose impact we're talking about. How research impact is interpreted and defined will depend on who you are and on what your context, position and motivation is. And the ref does often dominate in terms of definitions of research impact. And as we see here, it's a very laudable aim that the ref will see that impact is defined as an effect on change or benefit to the economy, society, culture, public policy or services, health, environment, quality of life, but beyond academia. And they're very laudable ideas, and they are quite high level. And I think for a lot of people, it seems very ambitious to achieve that. But I think that we can make it a lot more simple than that in nursing. And I think it's more about thinking intrinsically about what does research impact mean. And it does mean, to me, it means making a difference and improving the lives of people in healthcare. And if we think in that way, as researchers, those of us working in a research field, then I think it is about the good that researchers can do. And impact, therefore, then becomes quite a value-laden term, and one that can be understood in terms of beliefs and principles. And I think it's quite important that we need to focus on that aspect. So if we do adopt the position that impact is about doing good and making a difference, then we need to recognise the importance of these values and principles and the importance of being inclusive in our work, and thinking in terms of recognising the importance of equality, relationships that are two-way over a long time, that are nurtured over a long time with a range of stakeholders, valuing partnerships, valuing trust and empathy. So in nursing, if we're to develop research that matters to people and make sure that it achieves impact, we do need to recognise the importance of these things. So I'm now going to go on and talk about a number of strategies that are listed here that I think are important in terms of achieving research impact. So the first one is about challenging assumptions. And I've got a bit of a thing about this in terms of my career. And I think in terms of the research that's developed in nursing, very often the nature of that research does involve challenging assumptions. But for me, when it comes to the end of a project and we're thinking about implementing it, that's the other time that we really need to be honest about what assumptions we hold. And we need to be very wary that we have flagged up what our assumptions are. It's all very well to have a study that says drug A is better than drug B, but what if we don't know how people are going to respond to drug A, and we are just assuming they're going to take it, people are going to take drug A and comply with the research as delivered. We do need to be wary about these assumptions. And we might have evidence of effectiveness, but people don't always respond to that research in a way that we expect them to. So we have to scrutinise ourselves for our assumptions. The people in the audience who know me will know that I'm very fond of this comedian, Count Arthur Strong. So he'll make a couple of appearances in this presentation. So my first message is make sure that we talk to people, have those conversations, challenge your assumptions about how your research is going to be implemented. The other thing I think we need to bear in mind is about having adopting a mixed methods approach, and a lot has been said about this in different situations, but I think it is important to combine our methods so that they can be more than the sum of their parts. I'm not going to go on about this in the interest of time, but I do think by using methods together, it can be stronger and can really help achieve impact. It can really help in the implementation of findings. And I certainly think in terms of convincing commissioners of the power of your argument in terms of research, you can never underestimate the power of a good story from qualitative research alongside sound economic evaluation. So think mixed methods. The other point I'd like to make is that it's important to make the distinction between knowledge translation and knowledge transfer. They are both activities that are, or terms that are used very commonly in terms of knowledge mobilisation. So we have research, we have knowledge, we have experience, based intelligence. How do we mobilise that into practice? And knowledge transfer and knowledge translation are terms that are often used in relation to that. For me, there's a definition there of knowledge transfer, treating new knowledge as like a gift that's going to be transmitted to an audience, so from researchers to clinicians, and they will take it on board and act accordingly. Knowledge translation, however, although it's a hugely debated term, is very simply put the process that moves knowledge created into knowledge used. So it recognises that there's a process involved that we have to invest in and understand before we can't just assume, therefore, that research knowledge is going to be taken up. And again, knowledge translation will involve approaches like co-production and need those notions of equality, two-way communication, trust, and all the rest of it that I spoke about earlier. So I'm going to show some slides now which are from the TK2A theme. They've been developed by Dan Wolstenholme, and Joe Langley, who's a colleague, and have been devised by a fantastic designer that we've worked with over the last few years called Chris Redford. And so these show graphically the issue of knowledge translation and why it's important. So, and if anybody wants to know more, there's a paper written about it. So we can think that research is about getting experience and knowledge through experimentation. And after research is done, it's obviously shared in usual outputs that are highly valued in the ref. And that's where they end up. So these slides to people who were in the symposium that Dan ran yesterday will have seen these already. But we know that there's often a huge gap between knowledge generated and knowledge used. And knowledge translation is that activity which helps us understand why that gap exists and how we can narrow the gap. And really, for as long as I've been in nursing, we've been preoccupied by this gap. And I think it's as important now as it ever was. But we do have more intelligence now at our fingertips that will help us to broker that divide. Another way of talking about this is Mode 1 and Mode 2 knowledge, which, as Dan was saying yesterday, is talked about a lot in service improvement talk. So Mode 1 knowledge is similar to knowledge transfer, where we generate some knowledge from research, and it's assumed it's going to be implemented and taken up. Mode 2 knowledge, of course, is a bit more like knowledge translation, and it also generates new knowledge itself, and it recognises that we need to understand why gaps between research and practice happen and try and address them. But of course, it's what Mode 2 knowledge acknowledges is that this process isn't a linear approach. It can be quite messy, but it's also based very much on collaborations and partnerships and co-creation of knowledge and products that will help implement research into practice. So the next point is that co-production is suggested as the best way to do Mode 2 work. Now, co-production is a very contested term, and it's been used in a variety of ways. And in the last few years, I've witnessed many heated discussions about the nuances of the definition of co-production, and it can be made quite complicated. And I do love a model. I'm not decrying models, and I like this model. But I think we can overcomplicate things, and it's almost as if as a practicing academic or clinician, sometimes I think we can overcomplicate things, and if we do that, then we can make co-production appear as opaque and inaccessible as magic. So that's just a really corny way of getting Count Arthur in again. So, but what we do need to realise is that co-production is a way of people working together in order to generate authentic outputs and authentic knowledge, which will help us make a difference in practice and use our research. And What methods do we use to do that? Well, there are a whole range of things, some of which are here. So workshops, creative methods, generating consensus, developing prototypes, testing them, but also developing actionable tools. So just to stress then that co-production is based on challenging traditional power relationships, giving people who don't often have a voice, developing trusted working relationships, but also creating time. So moving on to the actionable tools, I'm just highlighting some papers here from colleagues Jo Cook, Susan Hampshire and others, some of whom are in the audience and would be happy to talk to you about it. But I'd just like to sort of highlight that actionable tools is a notion which is quite helpful, I think, for us in achieving impact. An actionable tool is defined as a product that is informed by research, that can change a way of thinking, promote a different decision or promote decision making, and or instigate action around a particular issue. And very often actionable tools are developed through co-production. So I want to move on now to a couple of examples to hopefully pull some of those strategies together. And as I was saying, these examples are ones that I've been really privileged to work with colleagues on. Both the projects have involved colleagues from the Translating Knowledge into Action theme, and both of them have utilised co-production and some of those other strategies in order to achieve impact. And in this way, patients and families have been able to be involved in an equal and trusted way. And I think one of the other things that's been really fantastic about these projects and the other TK2A work is the use of a designer in the co-production work. And I hope what will come out of the very brief summary of these presentations is how having somebody with design expertise in the room where you're having conversations is really helpful in sort of real-time capture of what everybody is saying, and then using that knowledge to translate visualizations of the discussions into actual products. So, the first project I'm going to talk about is called My Malignant Pleural Effusion Journey. And strangely enough, it was focusing on people with malignant pleural effusion. And as many of you will know, malignant pleural effusion is a condition common with people with a thoracic cancer, like mesothelioma. And I'm do a lot of research on patient experience with people with mesothelioma. Mesothelioma is usually due to asbestos exposure and affects the lining of the lung, and meso can lead to recurrent pleural effusions, which can have a significant impact, a negative impact on people's lives. A pleural effusion is an accumulation of fluid that is produced by the mesothelioma tumour in the space between the two layers of the pleural membrane. They can develop really rapidly. They can be the first sign that somebody has a presenting symptom of mesothelioma, cause severe shortness of breath and be really scary and have a profound effect on people's lives, and they can be recurrent. And there are various treatments and management techniques, including pleurodesis and indwelling pleural catheters. However, choosing the right treatment for malignant pleural effusions is really difficult and can be particularly hard in complex clinical and time-sensitive environments. So the project I'm going to talk about then, very briefly, was led by a chap called Matt Everson, who's a respiratory consultant in Manchester, and he worked with project leads in Bristol and London. And prior to the co-production work, which I'm going to talk about, these three teams conducted some research. They did a review of the evidence, and they conducted some focus groups and consultation work with patients. And the outcome of that research was that they identified there was evidence of effectiveness of about five different pleural effusion treatments. but it was very difficult to decide which treatment was right for which person, and there was no consensus about which treatment was right. And they felt that a decision support tool was required to help patients, families and clinicians in difficult clinical situations. And they also felt it was really important that patients and families and the broader MDT were involved in the development of that decision support tool. So co-production was the way forward. So the co-production team of TK2A were appointed to lead that co-production work. And that aimed to develop a prototype of the decision support tool which should then be handed on for development. So the co-production work comprised many stages, but in summary for this morning, the main elements were a local workshop, some design work, national workshops, and then designing and testing the prototype. The local workshops had a total of 24 patients and carers and 12 clinicians from across the 3 plural teams in Manchester, Bristol and London. And the local workshops involved patient cancer journey mapping and developing timelines to explore the pleural effusion management of patients. We developed storyboards that were developed to identify where information was received by patients that helped decision making and who gave that information. And this is an example of the storyboarding and the patient journey mapping. And but a key feature of the success of the work was having the designer Remy in the workshops, drawing and visualising what participants were saying as we went along. And these ideas were then used in between the workshops meetings to develop resources to develop the prototype. So the national workshop then went on to, as I said, Remy developed these resources to aid the discussion. So he developed some pen portraits, and these were used to discuss pros and cons of treatment options that related to each persona. And that really prompted us to develop some potential solutions to the problems. So the key findings from the workshops then were that managing pleural effusion was actually the first and major priority of patients who had recurrent pleural effusions. And until they had some confidence that their pleural effusion was going to be managed efficiently, they couldn't really think about the rest of their cancer treatment and journey. And I think that came across very strongly and was a bit of an eye-opener to some of the clinicians. They really valued consistent information and they wanted that from specialists. And they valued information in a variety of formats, but particularly visualizations. But another really important thing was that the factors that influenced their decision-making weren't kind of medical and treatment orientated. They were about their everyday lives, and how we needed to think how we could incorporate assessment of those things, like how active people were, their assessment of their own health, their distance from the hospital, all those sorts of things were really important in the decision making. So those things all had to be built into the prototype, which was then developed and tested and very successfully passed on to a software company for development. And I've just added a quote here, which was from a student nurse who took part in one of the workshops, who said that taking part in the co-production work was one of the best learning experiences of their training to date. So just being in a room with those mixed stakeholders and hearing those discussions, I think that's quite a powerful quote. So very, very briefly, I'd like to talk about the second project, which is about neutropenic sepsis. And as many of you will know, neutropenic sepsis is a life-threatening complication that can develop following the treatment of cancer. Patients require urgent assessment and treatment, and we've got very clear, nice guidelines around that. But it is a challenge because for most patients, neutropenia occurs while they're still at home, in between chemo treatments. But timely detection of that condition relies on patients checking and self-assessing a range of symptoms that they might have on a daily basis, such as a rise in temperature or increased tiredness. So it's vital that they look out for changes in themselves and report them to a professional. Now, the team that worked on this at Weston Park Hospital had developed a number of practice development initiatives which were very sensible, and they're listed here. But they were all very good stuff, but they weren't completely sure that they were tackling the nub of the problem and actually getting people to report early. So a project was developed. So Claire Warnock, who's in the audience somewhere over there with her team, led some preliminary research which has been published. This was both quantitative and qualitative. The primary aim of the research was to examine the value of temperature as a diagnostic and prognostic indicator in infection and sepsis in neutropenic patients. The secondary aim was to gain an insight into the presenting symptoms of people and also have an understanding of awareness and practices of staff and patients around temperature measurement to detect signs and symptoms of sepsis. So a cohort study was carried out using a case note review of 220 emergency admissions in a regional cancer centre. All participants were neutropenic and were diagnosed with infection on admission. But interestingly, the study showed, and the paper articulates in more detail, that body temperature is not a consistently reliable diagnostic or prognostic indicator for outcomes in patients with neutropenia and symptoms of infection. It can help assist with early presentation and recognition of infection, but there was a concern that we may be becoming too over-reliant on temperature and may risk missing the opportunity for early detection because of other symptoms. The qualitative research, some of the quotes are here, identified that people didn't always follow advice given for a whole range of reasons, feeling too unwell to do anything about it, not wanting to trouble anybody, not wanting to travel to hospital, feeling well despite having a temperature, hoping things will just get better, and attributing the symptoms to other things. So the research findings were complicated, especially when we think through how to overcome some of these challenges in practice. So body temperature, we know, isn't a consistently reliable diagnostic indicator. We've got an over-reliance on temperature. We know that people delay for a whole range of very reasonable factors, and so they might get a delayed diagnosis of neutropenia. So really complicated situation, and we needed a bridge from that research finding in order to translate it into practice and achieve impact. And co-production provided the way forward for that. And the aims of the co-production project was to understand better how factors influencing self-management and promote reporting of early signs of neutropenia. And we wanted to develop resources that were tailored to different patients. Not everybody responds in the same way, and so a one size doesn't fit all in terms of the information that should be available to people, and that's patients, families and staff. So we needed to identify ways to help staff communicate and advise patients and families. So the co-production process involved a similar kind of workshops that facilitated the revisiting of the data with an expert panel of healthcare staff. There was an iterative discussion, asking questions and sharing ideas as we mapped out the patient's journey and pathway, and part of that is illustrated on this slide here. By the end of the day, the team had identified goals, which were to reframe patient information messages, have a positive focus on living well on chemotherapy, but emphasise patients' role about self-monitoring and emphasise that as part of treatment, and also recognise that sepsis is a serious word and we need to use it when we're educating people to try and convey the importance of reporting early symptoms. Again, early pen portraits and personas were used to help facilitate further workshops and discussions with patients in different venues, and one of the team did spend a lot of time on the chemo day unit having conversations with people about our emerging ideas. Now, one of the actionable tools that were developed from this project was some I think the team feel a better patient information. So they're snappy postcards in my pocket, which were to help convey the information about early detection. And these also were developed by Chris Radford. So a lovely picture of Sheffield there on the postcards. And with some really accessible information on chemo side effects and, importantly, a call to action. So what to do if they occur. So the pen portraits that were developed are now used in staff education and help improve the education of patients by staff. The project is ongoing, and the team, many of whom are here today, do jump on any opportunity to share the work they've done, including joining the wider Trust in a sepsis initiative. So this is them out and about shouting their message about neutropenic sepsis and valuing the really sort of trying to achieve impact, which I really think that they have done. So I want to pull together now with some key messages from today, in addition to the points I made earlier. So first, I think it's really important to hold on to our intrinsic motivations and values when we're thinking about research impact, not just that big impact that kind of gets highlighted by the ref. We need to make a difference, whether that's to the patient in front of us or whether that's by rolling out the findings of a massive study. But achieving impact can be a matter of a long-term process. We need both those projects that I've spoken about today have taken years in gestation of clinicians desperately trying to have conversations and move things forward in between busy clinical roles. But using co-production can help to sort of bridge that gap and work with colleagues to help work pressured clinical colleagues. So impact needs to be planned from the beginning. It needs to be based on relationships across all stakeholders that are nurtured over time, and that activity of nurturing good working relationships needs to be valued as well. Resources are required, but I think there's a lot that can be done with very little. I think what we've shown, hopefully, with the two examples is that creativity and using design can help with the process. And we need to aim for tangible, actionable outputs from the research, and it's in that way that we can achieve impact. But I think one of the most important things, which I did say at the beginning, is that as clinicians we can enjoy this work, that it is really enjoyable. As academics, it is the good bit, actually thinking how we can implement the research that we can do. So my parting message would be to achieve impact and enjoy making a difference. And that is Count Arthur's last appearance. So there you go.